perfect. I mean, I love when it just goes to, it's all good the way that you've done it in the past. Okay, very good. Well, we will get started because we're just going to do this for about 30 minutes. I'm Dr. Jocelyn Fitzgerald. I am the social media editor of the Urogyne Journal. And this is our series on At the Scrub Sink, and where I get my friends who have written these articles to come and be on Instagram Live and chit chat about the topic they wrote about. So I'm here with Dr. Megan Bradley. I'm going to let her introduce herself. And for context, the article we're going to be talking about is on management of persistent stress urinary incontinence after retropubic midurethral slings.
Thank you very much, Dr. Fitzgerald. I'm Megan Bradley. I'm an associate professor in the Department of OB/GYN at the University of Pittsburgh. I am Dr. Fitzgerald's colleague. We are in our house. And I want to also give a shout out to Dr. Erin Mowers, who was one of our fellows at the time, who co-wrote this article with me, and I'm excited to talk about it today.
I'm so excited to talk about this too because I like this series because it's very practical and it's all about things that really frustrate all of us as urogynecologists. Obviously, we can read as many studies as we want, but when we have a patient in front of us who has a persistent problem after we've done what we know how to do to fix it, it can be very challenging to then decide what to do next. So let's just talk about slings, retropubic slings specifically.
Yes.
Are they your favorite procedure for stress incontinence?
I mean, they definitely are what I primarily did as a fellow. And then I think that we've done, thousands at this point, at least hundreds in the high hundreds. And I think that it is definitely a procedure that I'm very comfortable with. It's probably what I consider to be the thing I do probably the most common for stress urinary incontinence. But as I've gotten further out of training, I have realized that they are not perfect.
They're not perfect. Not that we were necessarily sold the idea that they were perfect, but when you're in training, you don't really see your post-ops long term. And I think we just quote like a very high number of success sometimes, but then in real life, they honestly probably are the correct numbers.
Yes.
But then you don't really get taught like how do you deal with what percent of slings would you say subjectively fail? And by fail, you mean they still have the problem they came before.
I think a lot of it is also setting up the ideas of like expectations too, because I think that obviously when you look at the data and all of our studies and everything that we do is very much like what is cure, what is better, what is improvement, does it need to be dry, does it need to be just better, and patient expectations are going to be different. And so I think that that's like a big part of it. But yes, I think that I just feel like you want to have a sling that's the patient's dry, they have no stream changes. You want that to be like for every patient, but I think realistically that's just not the case. And so, being realistic with patients, I think, so they have expectations that nothing is perfect. There's a small chance. I quote people probably like 85% efficacy,
Me too.
approximately, but that it's going to be different for every person.
Yeah, I think that's probably similar to what I do. I tell people like you probably have an 80 to 85% chance of you being happy with this.
Yeah.
And when I say that, that's me in my mind combining subjective and objective outcomes. The chances of needing a second surgery, we do know have this like longer term data now, like 20 years or so, and a bigger article that sort of show that right now this is the best thing we have. It's the most thoroughly studied thing that we have. Mm-hmm. But then let's talk about the person who comes back and they still are leaking. What do you do? That's what this article is about. Like, how would you tell a fellow to deal, like your approach? What do you do?
So I think, again, I do think that not seeing post-operative patients as much as a fellow, I really did think that they, despite seeing the reported, percentages in the literature, I kind of assumed that most people were better. And most people are better, but I think that I have had a couple patients over the last years that have come back and said, maybe they're more like 50% better, 60-ish% better, but still leaking with some stress maneuvers. We didn't really go into kind of also the whole other conundrum, which is patients that might have persistent urge or things like that. Yeah. So that's not really like what we talked about in this, like specifically patients who are still leaking with stress maneuvers. Maybe they don't leak as much, but there's a bladder a little more full. They're still leaking when they try to run, especially people who have like more high impact activities you're trying to get this sling to work for.
Sure.
And so I think that first, we talked about in the article that trying to verify what what the leakage is.
Right.
Obviously, I always want to see someone have a positive cough stress test at least prior to doing a sling, but afterwards confirming what volume they're leaking.
Yeah.
I know that the literature doesn't really support that like leak point pressures predict sling outcomes really, but sometimes I do tend to in these patients use like complex urodynamics to try to understand like how full is your bladder, like what is your leak point pressure, like do you leak with only stronger
like
efforts
bigger
versus lower,
volumes.
bigger volumes, bigger efforts, things like that, just to help figure out maybe why it didn't work as well as I would have hoped.
Right. And these patients, we've talked about, are very hard to like phenotype pre-operatively. Like we haven't come up with anything good to predict like who's going to fail a sling.
Right.
So yeah, people, I don't know, I think also subjectively on my part, people who come to me with like, well, I don't know, tell me what you think about what I'm about to say. Like, depending on how big their problem is, sometimes their like impression of their improvement can be very different. Like if they're having horrible leakage and then you cut it down by 60%, they might be like so happy.
Right.
But then some people who are leaking primarily with running or exercise, and then it's still like they have to wear a panty liner, they might be 90% better and still 100% unhappy.
Right.
It can be very tough.
Yeah, I don't know. Again, maybe I probably agree with you. I don't know if maybe others online are watching like or don't agree with it necessarily. But I also, I feel like sometimes we'll have patients who maybe they do leak a lot, but like only when their bladder's fuller, or like you feel like when they're running. I mean, that's a lot of impact on the pelvic floor to try to prevent. I have a line that I say that if that we are better at making people who are worse better. Like you said,
right.
And that if you leak quote once a month when you do CrossFit, like I can't really fix that. And I so hopefully I'm like getting my horse before the cart of people like are hoping that they only leak occasionally, like when they get a horrible cold or something, and that's probably not the person to do a sling on in the first place.
Exactly. I mean, so much of urogynecology is like the art of medicine, because you're kind of reading the patient and asking them like what they really want to get out of it, and then you have to almost like describe the sling in terms that they want to hear. I don't know, there's definitely like a piece to that. But anyway, to move on, like the definition used in the article is that these patients have objective failure. They come back, they still have visible stress incontinence on a cough stress test or on urodynamics. And then the question, I'm pretend I'm your fellow.
Yeah.
Like, Dr. Bradley, like, what do we do? What do we do now? What do we offer this person?
Yeah. So again, when I was a fellow, we primarily would talk about bulking versus repeat slings. The one thing that and we did a lot more kind of repeat slings. I guess I don't know if we got into the article too much about like fascial slings and things like that. But I guess my one interval thing that I talked a little bit about in this paper, because I have had the benefit of having a partner now who does transperineal ultrasounds. I have found this academically interesting. I think that we still need to study like what to do with the information that you find, but I have started to kind of use this in my counseling, because if I get the transperineal ultrasound and maybe the sling is like at the bladder neck or too distal, like because you can measure kind of location on your urethra, and then also the kind of sling pubis gap. I mean, the range for what is reported, at least like at our institution and in the literature, of like normal is kind of wide. So it's like 7 to 15 millimeters. And so, but if it was said it was 20 millimeters, gap, then maybe it is too loose. And that would like kind of sway my judgment towards like, okay, maybe if we just try to do this again, I get nervous about trying to make slings like a little tighter, because that's a whole, host of other issues potentially. But if it really is like above this standard deviation of what a normal sling pubis gap angle is, then, or width, then maybe I talk more about slings, versus if it looks like perfect, quote unquote, on the ultrasound, then I, maybe start to err a little bit on the side of counseling towards bulking. But but I more so tell them that that's not like perfect, and that's not like exactly, been out in the literature. So it depends on what the patient's goals are too.
Yeah, I do want to talk about that too. But I do like that this paper gives you this sort of very simple algorithm. Maybe I haven't looked at the right papers.
I thought you were going to say that your patients.
No. Just like everyone loves algorithms. In medicine, we love an algorithm. There's some very good algorithms for a variety of things, like mesh exposures and things. And in my recent knowledge, this is the most like algorithmic sort of way of approaching this that I've seen, with the use of transperineal ultrasound as like a pivot point. Whereas if you don't see the sling in the right location, I could totally see that. It's like, hey, I will counsel you more towards repeat sling as an actual solution to your problem than bulking. Because I think a lot of patients are like, can you do a second sling? And it's like, well, you can have 3 slings technically. I don't think I've ever put a 3rd sling in someone, but
no, I don't think so.
That's like I think a very good decision point. But then like what if somebody's just like, I just took off all this time from work and they're like upset and they're like, I can't take have lifting restrictions, which is another conversation for an Instagram live.
Yeah.
But I don't want to, or like they don't want to be not sexually active for another 8 weeks.
Right.
Like, how do you? But the sling's not in a great location,
Yeah, I still think, I mean, again, I don't think we definitively know that.
Sure.
There's probably, it's not like we're doing, it's a little bit of a bias because we're not doing the ultrasounds as much, on people where they're working per se, or like, having, research question. I don't actually know if they've looked at that. I'd have to read the, like, I know they've looked at sling locations, but I don't know if they actually have looked at like if they work or not, and like kind of
sling failure. Yeah, we'll have to dig into that.
We'll dig into that. But,
anyone in the comments, please send us the paper if you know where it is.
So, but I think, then I would talk to them about bulking, and I mean, I think it's my bias, but also supported with the literature, is I don't like, it's not my favorite thing to do because it feels like am I just kicking the can down the road to when they do need another sling? Because bulking, it's just not like long term the best. Like I would have rather have done bulking in a patient where maybe they just didn't want to do the sling in the first place.
Totally.
Yeah. So, but I mean, but some people, like you said, they're maybe they're better, but they want to see if they can get better, like they're 50% better. They want to get a little more better, and just continue down the road. But I think that I have gotten just more aggressive, I think, in my counseling in general, just about our things are not perfect, and that people need extra things, and et cetera,
they do.
et cetera. So to set expectations kind of prior to anything that we do, really.
Expectations are everything. I mean, I don't think you can. I don't know. Actually, I know there are studies that show just like literally how much the patient expects out of you, or even how much they like you. I remember maybe there was an OGS presentation predicts like how well the patient perceives the outcome. Like there's so much like psychological like movement towards what people think is success, depending on what mindset they take into it. We were chatting before we got on here about like the age-old question of urodynamic parameters. So like, is there any urodynamic parameter that you would use pre-op or even post-op, one in a sling patient that hasn't failed yet, that might predict their success versus someone who has failed? Is there anything you would do with any of those measurements?
It's hard to say. I mean, I don't think so, except that like, although I would have ideally known this beforehand, I think that like if someone did say that they maybe were only leaking at really high leak points, and that was what they were complaining about after the sling, I think I would probably just have a fairly realistic conversation with them that like, it's not perfect, or maybe bulking in that person, because like if the sling like looks normal and is working like in the vast majority of scenarios, but just not at like the height of, if they're leak point pressure, like they don't leak when it's 20, but they leak when it's like 140 or something like that, and you're like, well
that's a very high pressure.
I can't obstruct you,
I can't obstruct you.
And so
that is the problem. Is like people like really, I think, want you to like fix their problem, but I think even patients think they're going to be, speaking of playing the odds, like are going to be they're never going to be the small percentage of people who do have to cath or do have incomplete emptying or develop a new problem as a result of that.
Right.
And then when that happens, you're like, our goal was to try to make you dry, but now you're not emptying well, or maybe you have new urgency, maybe you, I don't even know, like have some your stream changes. People, get like upset about stream changes. So it's a very fine balance. I don't know, there's a perfect way of doing it. I remember when I was a fellow, it was sort of like an adage where we said, if you find ISD on someone's urodynamics, like after sling, you should go towards bulking. But what are your thoughts? Because we just kind of looked this up again.
Yeah,
and it seems
we found that
might be not very well supported.
Again, I think we're not talking about this completely, but we also were discussing earlier that I think, again, it depends maybe a little bit, right, on if a sling is maybe not going to work as well for ISD. I mean, I think there is literature for that. And I think that especially we talked a little bit about like if you've just done a concomitant prolapse surgery, and that was a really part of this, and we did the sling, and now you're worried that just like all the angles are off, maybe the sling isn't working because you've unveiled some ISD, like maybe that would bring me to think about the bulking, or like, you know, if patients are not leaking like right when they cough or sneeze, maybe just like lower volume, like dribbling or like and things like that, and they have really low leak point pressures, I might be pushed more towards bulking.
Yeah, for sure. Like someone who we were talking about patients like after sacrocolpopexy, and the data still doesn't really bear that out so much from what I can tell. But like I think clinically we all suspect that patients who have had a mesh-based repair that kind of hyper elevates the anterior wall like are more likely to have either like de novo stress incontinence without the sling or failure of the sling.
Yeah.
But we still don't have data really to back that up. But I don't know like what your clinical experience
well, I
is.
guess the only thing I would say about my clinical experience, again, and this is anecdotal, but like, and again, maybe it seems like you haven't had this happen to you, but I have had a couple slings that
I have.
are really, really didn't work like even all at all. Like, you know, and you're like, okay, well, like how loose could I possibly have made that? Like how I was like, I know what I'm doing. Like how bad could I have done that? Like,
the mechanism of the sling suggests that the loose ones should work too.
Yeah, right, exactly. And so like if I have had like maybe a couple patients where they like literally didn't work. And those patients, you know, I maybe bulked because I was like, okay, maybe there is some like unclear phenotypic anatomic something or other going on here that like you literally like a sling doesn't work for you. Like, I don't know.
Right. No, it's so hard. I like the thesis paper I wrote in fellowship was really on the what predicts failure of a interval sling. Like what patient characteristics could you say like would predict failure of a subsequent sling? It did find that like slings that are placed for somebody with really bothersome stress incontinence after prolapse surgery are much more likely to fail. But there's not a single urodynamic or phenotypic parameter that predicted who that would be.
Yeah.
And so I think there's something we don't, I don't know. What do you like? What could it be? I don't know what it is.
Yeah, I don't know, but I mean, it goes back to me again. That's not really what we covered in this whole thing, but you know, it is there's something up with like people who have prolapse and something about that whole thing because I have found, again, we're getting a little off topic of this article, but there's a lot of literature about, you know, slings and maybe not working in time prolapse repair. I was telling Dr. Fitzgerald that I just did a sling, a concomitant sling at the time of colpoclasis, and it didn't work. And then I did another sling and it still didn't work. And so there is something, no, I promise it's not me. They like
a patient, you know, something sticks out in my mind so much. Like she failed everything I did. I did a sling. I bulked her more than once. It's even possible that I took her for a second retropubic sling and that still didn't work. And finally I did a fascial sling, which is beyond the scope again of this by the scrub sink. But I mean, I guess if we came even farther down the algorithm, we could.
Yeah.
And then, I mean, I really counseled her strongly, like, you probably will never pee normally again.
Yeah.
And it should take like months for it to settle out. And like now she's doing better, but I mean, I was just like banging my head against the wall. I didn't know what to do.
Well, I do think that, I mean, another couple things, you know, that, you know, I was thinking about how to tension. I mean, we don't have good data, you know, behind how to do that. It's like there's not a standard talk about lack of an algorithm.
Totally.
There's
It's
really
all
no
just
algorithm
gestalt.
on that. Yeah. But I was saying to Dr. Michelle before we started that you have started to like experiment with making slings like a little tighter.
A little tighter.
You know, but and those
we don't have like a measurement of tightness at all.
We do not. Like there's no measurement. But I have those patients like do note like a little bit change in their stream. So
yeah, for sure. It is funny, like we obviously share the same fellows and the faculty in our group have all been trained, many of them in different places at different time points. And so they report back during cases like how different attendings tension slings differently or little different things that they do. And for all of the differences, I bet it all comes out in the wash. Like, I mean, it's very funny to hear them say like this person makes them way tighter than you do or this or that and the other. And I haven't heard like the people who like our nurses or our APPs who see our post-ops like really, I don't know, they've never said anything to me about them different and they're all basically working the same.
Right.
So anyway,
I would say that I was, you know, always, you know, I think that in terms of counseling for the patients, even that I do the repeat sling on, I am fairly aggressively a bit, I'm like, okay, we'll
Sure.
do this again, but I do not promise. I'm like, there
For
might
sure.
be something up with you and your anatomy and
Sure.
something that like there's a reason why the first one didn't work as well. And so the
Definitely.
second one, I'm really only quoting them maybe like 50% success at getting like better than they are,
Yeah.
opposed to the standard, because again, like you said, they're supposed to just work kind of.
They're supposed to
like,
just work.
no
Yes.
matter what you do.
So like, I guess in our last few minutes, like, what would you add to this algorithm if you ran the world and had a research wish list? Like,
Yeah.
what,
Um,
where do you think the future is headed? Like, what
maybe
is,
like something dynamic.
okay.
Because yeah, like I think something dynamic, like whether or
Okay.
not you can image while someone is doing
Sure.
their urinary, like
Yeah.
coughing, or like
Mhm.
the leak is actually coming out, so you can do some like physics and
True. Yes.
to try to figure out like
Hydrodynamics.
like what it looks like dynamically when some whistling is working for somebody
Mhm.
versus like what it's doing more
Yeah.
dynamically for someone that's not working for
Totally.
them.
Some like maybe AI modeling where it's like, okay, this is whatever the angle or the flow or the
Yeah.
speed or the pressure at which it's doing it. So I'd recommend like this material, and you
Right.
based on this lady's urethra, this is where I would put it, and
Right.
this is how tight I would make it. It's like,
Exactly.
that would be amazing.
Yeah, that would be the best.
There's probably some role. I don't know. I know that our fearless leader Pam O'Elley
Yeah.
like works on this.
Yeah.
Like regenerative medicine, like a piece as a
Mhm.
salvage
Yeah, sure.
procedure. I don't know. Maybe
Yeah.
someday I feel like that would be more first line than salvage, but I feel like there might be a role for that someday. I don't know.
Especially because like
Maybe.
you can maybe consider a sling. I think a lot of the stuff with stem cells or whatever, it's more injection in the area, but using maybe sling as like a scaffold for that,
Sure.
like, right, like maybe
Yeah.
put the sling in and then scaffold it with stem cells to like get them in
Yeah.
the right spot,
Right in
or
the
something
precise
like that,
location, like some sort of, nuclear mapping or
Yeah.
something crazy.
Yeah.
For anyone listening with some money and some research
Yeah.
time, we're giving you lots of ideas.
Exactly.
But great. I think that's like mostly what we want to talk about. Any
Yeah.
last thoughts?
No, I don't think so. I think, like you said, I think that just as I've gotten further out in training, I just have realized that it's just about setting expectations with people. And if you kind of are, getting vibes that patients, really are someone who's not going to be happy if it's perfect, you really got to have real conversations with people that it's like, it's
Yeah.
easy. You think it's easier to be like, oh, we'll do a sling, it's
Sure.
gonna be fine. But, really guideline expectations, goal setting, and kind of trying to figure out, what's going to make
Yeah.
that patient happy and make sure it like goes along with, their goals.
Yeah.
I
It's
think.
like an emotional intelligence algorithm.
Yeah.
That as much
Yeah.
as it is a treatment algorithm.
Yes.
Well, very good. Let me just look real quick, see if we had any questions. I know it's like a sort of mid-afternoon, so probably not, but this will be available. Oh, sorry, I'm moving the thing. Well, we'll just leave it there. This will be available on the Augs grid. So we moderate all the comments, and if you have any questions, we'll take a look at them and try to find an answer. And I hope you'll read the article and share it with your fellows. So thanks so much.
Bye.
Have a
All
good
right,
day.
thank you,
Bye.
Dr. Arlene, Dr. Fitzgerald, and everybody who joined.
Thanks.